we're going to move on to our last session with Dr. Iliescu, talking about carcinoid valvular disease and RV failure. Please.
Thank you all, and thank organizing committee for inviting me. I'm a little bit, I try to be short and cover a big area and dear to me of this new cardio-oncology field. And I'm going to start with a clinical case, a 60-year-old patient with kidney failure, lymphedema, fatigue, and some weight loss. And that's very interesting, and it's very unusual. Sometimes carcinoid disease presents with retroperitoneal fibrosis, and that's the reason why the heart failure. So the patient mentioned some diarrhea, but was not main driver of the symptoms and of the complaints. She was diagnosed in the end with neuroendocrine tumor and was treated with somatostatin analog, so basically long-acting lanreotide. And then we did an echo, and the echo is absolutely classical. There's any view you can look at the wide open valve with a severe tricuspid regurgitation with triangular jet, and of course as much flow forward as much flow backwards. And the carcinoid, as an overview, carcinoid disease, out of carcinoid disease, half of the patients can develop this carcinoid syndrome, and I'm going to go more into that. I'm going to go about the involvement of the left side, why it's important, and what kind of valves we're using in them, how not to get to RV failure, and of course the new therapies that we have available in this field. And it's interesting that majority of these patients you're worried about carcinoid heart disease have ileal and cecal disease and not pancreatic cancer. So all of a sudden the pancreatic tumors are very unlikely to cause carcinoid heart disease. So my main focus is, when you hear ileocecal disease, is to focus on the carcinoid disease and its prevention, carcinoid heart disease and its prevention. And it's interesting, the cycle of tryptophan, I'm not going to go through this, but it's very interesting. We have new therapies that block the production of serotonin, and one of them is the telotrestat, which is a new agent that oncologists are using for diarrhea, and you're going to see how we find the use for this one in preventing carcinoid heart disease. And of course, in all this cycle, we very seldom, if ever, we check the levels of 5-HIA or the level of NT-proBNP in this patient population, but actually the values do matter. You're going to hear a lot of oncologists disregarding these values, but the reality is any level of 5-HIA above 300 is associated with increased mortality, as well as the increased level of NT-proBNP above 260 associated with carcinoid heart disease. So those numbers, we can check them in clinic and monitor them to see how much and extent of disease. And it's not trivial. For every 10% increase in the level of 5-HIA, we have 10% increase in mortality. So that's a dramatic level. And I can tell you from a cardio-oncologist perspective, so the lower level of this poison, which I call it the 5-HIA, of course, the lower chance to have disease and valve involvement. So and you're going to see the story better in the graph. But long story short, the first mention is, for everybody who's in the audience, is when you order an echo, it's not just an echo, it's a 2D echo with agitated saline, because all these patients, you have to make sure they don't have a PFO, an ASD, or lung involvement. And you can see this patient that I'm presenting in the initial phase also had eccentric mitral regurgitation and some aortic insufficiency as well. The second mention, of course, if you have a PFO or an ASD, continue monitoring aggressively the mitral valve and aortic valve, and it's not maybe unreasonable to close the PFO or the ASD to prevent the valve deterioration on the left side. Again, we're talking about everybody do an echo, but not a regular echo. So we talked about echo with agitated saline and with focus on the pulmonic valve, because anybody can see the tricuspid valve. But the pulmonic valve is the Achilles heel, and the data from Mayo Clinic, they're almost like 40 years old. They mentioned 80% of the pulmonic valve is involved. So even if you don't see it, it doesn't mean it's not involved. And Manish is here, so basically they always inspect the pulmonic valve. So it's part of the protocol, replacing an FACC is here. So again, it's just standard. You go and you assess the pulmonic valve, even intraoperatively, even if your echo is not mentioning, MR is not mentioning it, the valve is very likely affected. So out of all the patients we've done, I think 2 or 3 would not replace the pulmonic valve. So in majority of these patients, the pulmonic valve needs to be replaced. And actually, it's a lack of awareness, and our talk today and other people's talk increased awareness about this one. You can see in national patient sample, we're recognizing more and more the need of replacing the pulmonic valve, and it's a positive trend that's not associated with increased cost and it's or increased length of stay. And this is a beautiful case report where you can all appreciate the severe tricuspid regurgitation, the CT chest where you can see the aortic valve is closed, but the pulmonic valve is wide open, so the valve is absolutely wide open, pulmonic regurgitation, and you can appreciate that also on the MR. So there's no discussion. These retracted, rigid pulmonary cusps are seen on the intraoperative time, and was obviously on everything. And you can see the pressure volume curves. The gray ones are the normal volumes, and you can see a dramatic shift to the left of the left cardiac output, and the increase, of course, on the right ventricular side pressure and volumes. And this is the story of the RV failure. So we talk about RV failure in the perioperative period, but the reality is not an RV failure. It's actually an LV underfilling from the severe regurgitation on the right side. And before we started systematically doing the surgeries, we started doing systematically left and right heart catheterization on these patients. And to our surprise, despite the fact all these patients had severe tricuspid regurgitation on echo, and there's no doubt it's torrential by any criteria you can think of, actually by hemodynamics they're not all the same. So we had three obvious categories. A category with preserved A's and V's. Despite the severe tricuspid regurgitation, the A's and V waveforms are completely preserved. And actually IVC is collapsing nicely. And I think these are the patients you're going to see them for 10, 12 years without valve deterioration. They are doing fine. And that's why we have this myth about tolerating tricuspid regurgitation forever and don't have to fix the valves. Then the second category, I think it's a whole progression. The second one, they evolve these tall V waves. And the last one is ventricularized. So I think it's a progression of the severity of tricuspid regurgitation that you can, and it's reflected by hemodynamics in different stages. And actually, this patient you can appreciate at really tall V waves. You can see that all these patients that we call, so again, whoever's in the audience and calls a tricuspid regurgitation in a patient with carcinoid heart disease that they have pulmonary hypertension, it means they've not seen this patient, they've not done hemodynamics. We have not seen a patient with carcinoid heart disease having pulmonary hypertension. So they all have normal PA pressures and normal wedge. So this is, again, very, very important to know. And again, the correct statement in the echo report is unable to appreciate the PA pressure or any measurements because of the severity of the regurgitant jets. And this is the data from our group. So you can see the three categories. The first one in black is preserved A's and V's. And those with tall V waves have similar survivorship, different than those with ventricularized waveforms, which have, again, dramatically worse survivorship despite all of them surviving the surgery. So I think that these waveforms have predictive values, and I think this is why we have to be cognizant and have a low threshold to assess hemodynamic in these patients. Now, that being said, is what happens is we've seen, so it's very, very interesting concept. So initially when we do the right cath on all these patients, we've done systematically cardiac output by thermodilution and FACC. And it's interesting in the preserved A's and V waveforms, the cardiac outputs do correlate. So despite everything we've learned in hemodynamics, in this patient population, when we have preserved A's and V's, cardiac output by FACC and thermodilution, they correlate. We see exactly the same number. As we evolve towards the tall V waves, you can see a dichotomy of the cardiac output by FACC and thermodilution. And by the time we get to ventricularized ones, majority of them, we looked at them and you're going to see our data, 88% have significant dichotomy between the cardiac output by FACC and thermodilution. With the cardiac index, you can see all below 2.2. So all these patients are hypoperfused. That's why they have deterioration of the renal function. That's why they have deterioration of the overall functional status. We have a liver that's half metastatic to begin with, and on top of that, we have a low cardiac output state. So of course, we're going to start having the INR going up, the albumin going down, and we have this spiral that we cannot reverse. So it's very, very interesting is once we started doing earlier surgery on all these patients, we've not had in almost 80 patients a patient with RV failure perioperatively, which is absolutely humbling. So it's not an issue of the RV and RV failure. RV actually recovers at 2 weeks, almost normal in size, normal function, normal everything after surgery, but it's just a failure of us recognizing the timing of valve replacement. I think we're waiting too much, and I think we get to in this ventricularized waveform where all these procedures are too late. We've had, again, experience, and Sriram is here, again, 70, 80 patients we've transferred, and Carlos is here. So basically we have 80 patients we've done surgery on right now with their group. We had one patient with hypotension at induction, And basically what we did, we held procedure, we did additional strategies to reduce the level of circulating serotonin, and then the patient was operated at the time, no episodes of hypotension. So if you feel when you get the medication a drop in blood pressure during induction, that's a good sign to escalate the cancer therapies. And I'm just going to go very fast through this. Again, surgical valves are bioprosthetic. No discussion about that. We cannot anticoagulate these patients. The story is octreotide with Coumadin should increase the level of Coumadin. Actually, with Coumadin of 15 and almost 20, we do not achieve therapeutic INRs, so it's not the case. The risk of surgery is zero in our patient experience. Again, they've done all the way to 4 valves with some residual mitral tricuspid stenosis and pulmonic insufficiency. And the last one is we have basically, this is the story, and I'm going to finish here. So this is the patients when they come in, they initially assess. You can appreciate on the screen the level of, I cannot show you. The level of serotonin is extremely high. On somatostatin analog, the level decreases dramatically. But with the new medications, which is one of them is this telotrestat, but also we have PRRTs and we have liver embolization, the level of serotonin decreased further to where the valves are not damaged anymore. So we had no redo of the valves in our cohort. All the patients we've done surgery on, they didn't need any reintervention. So to conclude, there's no pulmonary hypertension in this patient population. The right atrial hemodynamics have prognostic value and it can prevent this RV failure. So early identification of the correct patient population as substrate will prevent, again, the RV failure in carcinoid patients is basically the hospice diagnosis. There's no other options for those these days. The 12 V waves are kind of the cutoff for us to go for surgery. Ventricularized waveforms need better assessment of the risk-benefit before we go for surgery. Thank you.
Very, very nice. Let me ask you a question. I mean, first of all, that was an excellent review for a somewhat rare disease, but I was going to throw that back at you. Do you think we're underdiagnosing this just because patients don't have diarrhea? You made the point about the fact that maybe we should be potentially measuring some of those levels in TR patients. What do you think the sort of equipoise point there is to do a thing like that? And then have a second question for you about potentially using percutaneous valve replacement.
Beautiful, both questions. So the first one is actually, I'll tell you the story. So one of our trainees actually, with strong family history, diabetes, everybody in the 30s, and CAD bypass in the 40s, decided to have his birthday present, a CT scan, CT coroners when he turned 40, to know where he's standing for. And actually, he got the upper part of the liver with metastatic liver disease. And basically, minority Hispanic, was blown off for diabetes and diarrhea because of the metformin for, talking about 7 years before he got diagnosed. So when we looked at the national patient sample in this patient population, Hispanic population, again, dramatically under-recognized carcinoid heart disease because of that. So to answer your question, the answer is a big yes. The second one, it's a huge delay from diagnosis, from the initial symptoms to diagnosis. Again, we have all these patients. We have now a case series of 4 patients with retroperitoneal fibrosis with renal insufficiency presenting sign, and after that, diarrhea way later in the course of the disease. So by the time we get diarrhea, already almost on dialysis. And then we stent the ureters, and then all this all the kidney function recovers, everything recovers. So the driver is actually the fibrosis, which is retroperitoneal this time, and not cardiac, valvular, anything we know. The second question was about the valves. So the biggest problem we have is the ventricle is big to begin with, and it's not calcified, so there's nothing to anchor on it. So once you put a percutaneous valve, you doom that right ventricle to be huge forever. Once we put a valve, of course, we cannot do an annuloplasty. We cannot do that. So Manish and the team, they do a superb job. They basically have a small ventricle in 2 weeks. It's almost unbelievable, the resilience of this huge RV that you think will never recover. And in 2 weeks, they're all normal in size, normal RV function. So the biggest issue, and I forgot to tell you about that, is that actually after surgery, it's interesting, we monitor the pulmonic valves. So everybody gets a tricuspid and pulmonic valve, and the way we monitor them is every 3 months with echo. The pulmonic velocities go up, not the tricuspid, because what happens is these are not pristine patients. These are treated patients. So the level of poison goes down from here to here. Now the tricuspid valve gets low pressure, no turbulence, not a lot of turbulence across it. The ventricle closes, the tricuspid is closed. But now we have on the outflow turbulence and the small level of poison enough to basically modify the pulmonic valve velocities. So we got back to our oncologist and we told them the mass is unchanged, I got it. There's no diarrhea, no flushing, I got it. But it's messing our valves. And they said, no, everything, disease is controlled. And I said, no, disease is not controlled. There's a certain amount of poison, not enough, you can see it at your level, but it's enough to see on our valves. So pulmonic velocity 2.1, 2.3, 2.5, 2.8. On anticoagulation, it's not thrombosed. We can see the leaflets moving. It's just the valves are getting thicker and thicker. And there's no discussion about that. We see beautiful 3D TEs where we see the pulmonic valve thickening. So then finally they decided and they started this telotrophy test for low disease burden, PRTs, liver embolization. We've not had the patient, and Biswajit is here, we've not had the redo of any valves in 17 years. But it's an active process where we're actually like oncologists in the sense we get this early lack of control by visualizing velocities across the pulmonic valve, the most common, the main trigger of deterioration.
So guys, we a little bit went
Fantastic.
over time. This because it was a little bit different cardio-oncology in the shock symposium. If the panelists have one last comment, because we had the last session, so we can take the liberty before we send everybody to have some fun in the city of Houston.
What's about to implant two valves in the cava inferior and superior? What's about this strategy?
Super question. The issue we're having is, again, we talked about this one, and also you're left with the pulmonic valve, so you have to do also the pulmonic valve. If you start doing those, you have to do the pulmonic valve. It's interesting is why this patient population is completely intolerant to pulmonic insufficiency. So you think, from everything we've learned that pulmonic insufficiency should be well tolerated, but these patients fail and spiral down. And on MR and everything we've tried, and even in the surgery they did biopsies, we do not see a significant amount of fibrosis, but it's there. It's exactly the same thing with radiation. There is fibrosis there, and somehow we cannot quantify in any way. So I think that ventricle is failing, so we have to put a pulmonic valve, and then we're talking about this. We've had a discussion about two patients, we are not able to qualify them. So of course you have to have landing zone above the liver, so enough landing zone to put the stent in. And we found it again, in this patient population, you do maybe for symptomatic relief and short term. Reality is right now we're pretty aggressive in identifying them, do the hemodynamics. We saw first symptom or tall V waves, we send them for surgery, and we've not had zero mortality for the surgical procedure. So like we see no reason.
Do you concern about the left ventricle in this situation? Because if the right ventricle fails, does not pump enough to the left side, but then you restore the normal hemodynamic by putting two valves in the right place, then do you have concerns that the left ventricle will struggle with the normal amount of blood?
No issues, absolutely no issues. Zero issues, absolutely. The recoveries are actually unbelievable.
No, I mean the left ventricle. Because
no issues, zero issues.
In pediatric population, we have some patients, older patients, 50 plus. We put the pulmonic valve, so the like melody, and we put simultaneously impeller for 3, 4, 5 days just to help the left ventricle, fight with the normal hemodynamic. You don't have this.
Even the patients they did 4 valves actually had no issue with the left ventricle. Somehow it's just
most
on
of the time
but no other
the
issues.
ventricle is preserved, and Dr. Nathan can comment more about it because he follows them also in the post care. But the RV and LV function, as you mentioned, PVR is not an issue. This is all like a wide open most of the time. As you mentioned, when you look at the valve, there is no valve. It's everything just, it's just, fibrose. And also similarly, you're not going to see about the pulmonary valve, but there is always the PVR when you explore. Dr. Grigorek, over time, after 80 cases, we got down the very nice time, the procedure-wise is that pretty quick procedure. Recovery is good. Most of the people get fast-track extubated. So that's why the consideration of percutaneous valve, even though these patients look very frail and sick, but they do very well.
David, last comment.
Yes. Yeah, I was just going to quickly say, to generalize all this excellent talk, when we talked about under-recognized carcinoid, there is a cohort of individuals based on their size, so people who have a low BSA, who are on a combination of, with an increased awareness with mental health, or on a high dose of a serotonin inhibitor, I had a young lady who was 90 pounds, had a chronic cough, took dextromethorphan every day, and she was on a high dose of a serotonin inhibitor, which of course is not based mg per kg. And so this lady that was 4'9" showed up with carcinoid syndrome from her pharmacologic mixture of well-intentioned drugs.
Right, an unrecognized thing that we need to think about. Were those patients on metformin that we take off who still have diarrhea with diabetes, maybe on TR, maybe we should be ordering an HIAA. This has been a great session, a great panel. Thank the speakers, thank the audience. Go enjoy tonight.
Enjoy.